welcome everybody. This is the intersection of U.S. drug policy and the treatment industrial complex. So, welcome to our panelists. We have Kevin, Luna, Ben, and Rory. So, hello everybody, and I'd love for you to go around and introduce yourselves. I'll introduce myself. Hello, everybody. I'm Rachel Wissner. My pronouns are she or they. I'm the Director of Development and Communications here at Students for Sensible Drug Policy. And I'm really stoked to be here virtually with all of you today. All right, so let's start with Kevin.
Hey, how's it going, everybody? My name's Kevin Garcia. My pronouns are he, him, él. And I'm a alumni of Students for Sensible Drug Policy and currently the secretary for the MSU Denver chapter here in Denver. And I got involved with SSDP sometime in 2014. After that, I became a chapter leader for Florida International University. I worked alongside Luna as well as Lewis. I was on the board of directors for a bit in 2016. And right now I'm working as a harm reduction content expert for Next Distro. I know, I'm happy to be here.
Thanks, Kevin. And next, let's go to Ben Levenson.
Hey, everybody. Thanks for having me. I'm looking forward to the next hour together. So I'm chairman of the Levenson Foundation, and kind of my relevant background with this topic is that I, like many, kind of grew up in the traditional frameworks of American treatment and ended up operating at a pretty high level as an administrator and as a stockholder in a system that was located between Texas and Florida. And I started going abroad in 2013, working in Gaza and the West Bank and abroad, and into Eastern Europe with really disadvantaged populations, and just had this awakening that started to happen that the ways we fundamentally interface with and care for people who use drugs is super jacked. And so I just feel really fortunate to be here with you today. The foundation works to kind of lower barriers, improve access and quality to harm reduction informed drug user healthcare, including family members. And I get to do a little bit of policy and advocacy work as well. So again, good to see everybody. Thanks for having me.
Thank you. And I think, Luna, are you still having technical issues? I saw you left and jumped out. You good now? Okay, cool. Yeah. All right, yeah, go ahead and introduce yourself.
Yeah, so my name is Lunadelmar Suescun. My pronouns are she, ella. I joined SSDP in 2016, and I was just elected onto the board of directors this year. My experience, I worked at a syringe exchange for 2 years as a case manager. I was part of the Florida International University chapter when I first joined SSDP, and that's kind of how I first started learning about the war on drugs and drug policy and harm reduction. And then since then, I've been able to gain a lot of experience and work in the fields that I'm interested in, and try to do my part in ending the war on drugs.
Thank you. And that's, lastly, we will go to Rory.
Hey everyone, sorry, I was having some technical difficulties here. I'm Rory OBrien. I started going to school in 2018, I believe it was, for addiction counseling at my local community college. Before that, in some of my sociology classes, something that really interested me was the history of the war on drugs and how it's impacted communities of color. So I tried to bring that into my work with studying addiction counseling, and kind of notice that that wasn't a lens that people were looking through when they were getting into addiction counseling or even the addiction counseling courses. And then in 2019, we founded a Minneapolis college, Students for Sensible Drug Policy, on my campus. And that summer, I became the chapter leader. And now we've switched to Minneapolis Students for Sensible Drug Policy, so it's not connected to a specific college campus. And also, I'm a person in recovery. I kind of describe it more as being in recovery from trauma, like I'm in trauma recovery, instead of sometimes how it's framed for being in recovery.
Thanks, Rory. Let's move to our first question. What is relevant to the audience about your connection to the topic? We'll start with Kevin.
Hey everyone. So I guess I would say that my experience relevant to the topic is both from work and from lived experiences. I guess I could say I'm in recovery from a problematic relationship with drugs, and I've worked in rehabs. I've worked as a prevention counselor for children. Worked on the harm reduction side on a syringe exchange, doing street outreach, and I've been on the advocacy side as well through my work with Students for Sensible Drug Policy.
All right, thank you, Kevin. Now, Ben, what is relevant to the audience about your connection to this topic?
Yeah, thanks. So I have pretty complex lived experience and just personal connection. I grew up kind of around recovery. My mom is 30-something years abstinent, and I lost a brother to an overdose of the first OxyContin formulation the same week that the towers came down in New York, which I lived there, and so I had a connection with that. And have been at times a super chaotic drug user myself, and was able to work to kind of move through the problematic relationships or relationship with substances. And then, as I mentioned, professionally, I've worked in the field advocating originally with populations and caring for populations who had recently stopped using substances, which is one of the hallmarks of our system. But we're super fortunate, maybe 10, 12 years ago, to have been able to pivot or begin to pivot my attention away from the population who no longer is active in their drug use and focus on the much broader cohort who are active in their drug use, including millions of Americans who, in fact, the vast majority of Americans who don't have a problematic relationship whatsoever with substances, but who use drugs.
Thank you. All right, Luna, so what is relevant to the audience about your connection to the topic?
Yeah, so I had experience working in a syringe exchange, and I provided case management. And that part of the work that I did with folks was often included a desire for treatment. So my connection comes from supporting people who use drugs, who are in various stages and in various types of relationships with not just one substance, but just multiple substances at a time. And I think that's kind of like what has like helped me kind of just like frame my views on the treatment industrial complex and how it kind of interacts with U.S. policy.
Thanks, Luna. Okay, and Rory, same question to you.
So I had mentioned already that I was an addiction counseling major, and I did my first internship at a methadone clinic here in Minneapolis. I tried to get involved, and actually our SSDP chapter has as well, in kind of some of the treatment industrial complex intersections for policy. So for example, we did legislation or supported legislation for studying sober housing, and kind of looking into what can be changed there to kind of more honor people who use drugs and their autonomy, and also just so it isn't looking into how it's fueled by money and completely unregulated. And then also just I do have family experience too with addiction. That's kind of what got me into wanting to do addiction counseling, other than being very interested in how the war on drugs has impacted communities of color.
Thank you, Rory. So my next question is, what does the term addiction treatment industrial complex mean to you? So let's go in the reverse order of what I just went. So we could start with you, Rory.
Sure. And when we were planning this session too, we were talking about how it's such like kind of a broad definition and it might vary per person. To me, the addiction treatment industrial complex is, it functions in similar ways that other industrial complexes do, like the prison industrial complex. And it kind of does feed off of like oppressive systems. Well, it is an oppressive system, but it feeds off of other oppressive systems as well. And there's nonprofits who run treatment facilities, but it is very much like a people or a profit over people industry.
All right, Luna.
Yeah, so for me, it kind of similar to like how Rory said, it's like it's a system that puts profit over people. It's just about oppressing and shaming others, usually through forced treatment, whether it is forced through like because they're in drug court, or forced because they feel like this is the only option for them to live a happy life or be accepted. And it's like a system that doesn't meet needs. It coexists with punishment, whether through the for-profit prisons or even with like schools mandating treatment. It's just present in a lot of different areas. That's usually takes from like taking away autonomy rather than just helping people like do what it is that they actually want, and instead of like instilling their own thoughts onto others.
Thanks, Luna. Okay, take this question, Ben.
Yeah, so this is a question that doesn't have maybe certainly not a perfect answer, and maybe not even a right answer. I think for me right now, when I think about the words treatment industrial complex, I mean, they have super negative connotations for me. And I know that all systems of care aren't, necessarily bad or entirely good, nor the people who operate them. However, I think the treatment industrial complex tends to be programs that have fundamental conflicts of interest with between kind of their own business interests and, let's say, the interest of their patients. They also probably have a lot of different stakeholders, whether that's the justice system as their primary referent, or if it is stockholders, families, and even interventionists and others. So yeah, it's a little bit nebulous, but I think it's for me, it's a system that is super ripe for disruption and completely out of step with the realities of drug use in America, and needs to be forced or otherwise reformed. And I think that we're gonna maybe get to talk a little bit about what that looks like today too. So thanks.
Thank you, Ben. Okay, Kevin, go ahead.
Yeah, so when I hear the term addiction treatment industrial complex, I hear treatments that don't work for most people, treatments that are prohibitively expensive for most people, and treatments that generally do more harm than good. I feel like the war on drugs, the disease model, 12-step programs, all of these things focus on the drugs, and that depreciates lived experiences by targeting resources on drugs and alcohol rather than the conditions of people's lives. And it also serves to disempower people and provide a convenient excuse for those in power to avoid the deep changes needed in order to reduce inequality. And just as a little background, I remember I worked at a detox center, And these folks own detox, they own the inpatient rehab, they own the hospital, and they own the halfway houses. They own all of that. And so essentially they would just be getting people to like go in this cycle of their centers making that money, like, oh, you can't do the 7-day detox because of XYZ. We're gonna throw you back in the throw you back in rehab. Oh, you can't do rehab, back to detox. Oh, you had a overdose of detox because somebody snuck in fake Xanax bars. Take you to the hospital. Oh, you managed to complete the program. Let's put you in a halfway house. If that doesn't work, let's put you back in the detox. And I feel like, I saw oppressive practices being done. Like, they would fly in people from like another state and tell them, hey, you have 30 days to complete this program. If you fail to complete these 30 days, good luck getting back home. Good luck getting a plane ticket. We're not going to provide that unless you could stay here 30 days and we could charge insurance money. And so essentially, that's what I think of when I think of addiction treatment industrial complex.
Yeah, thank you, Kevin. So, like, related to this, actually, when I was advertising the session on my Instagram, when I, to promote the session, a friend of mine DM'd me, and she told me that her boyfriend is at a rehab right now that's also owned by a company that manufactures opioid drugs. So that's pretty interesting. Yeah. So our next question is what movements and initiatives intersect with the treatment industrial complex? Let's start with Luna.
Yeah, so I think, like, as we all have said, it's connected with the prison industrial complex, with mental health care and forced diagnoses, and movements against carceral punishment and family separation, like the child welfare system. Pregnant and parenting people who use drugs often undergo persecution for substance use, and the majority are forced into some sort of substance use treatment. And even if they're not diagnosed as substance use disorder, that's like put onto them. I feel like drug use isn't inherently bad and it doesn't make people bad, but it seems like it's more like accepted for people who are not parenting. So the child welfare system is really involved with the treatment industrial complex by being like, oh, okay, you use drugs, so we're either you complete this program the way that we tell you, which is like abstinence only, or you're never going to see your child again. So I think that's something that's really important to highlight, because just like the war on drugs is a tool of racial oppression, and so is the child welfare system, and so can the treatment industrial complex, especially when in the child welfare system, when like Black and parents and families are disproportionately represented in this, and they're the ones that are usually having their children taken away.
Yeah, that's a piece that's like not often spoken about, or is like one of the most like stigmatized subjects when we talk about rights for people who use drugs, where like parents are very much persecuted, and so are pregnant people, and it's like, it's like one subject that, like, a lot of drug policy reformers I know don't even want to touch that because like it's very sensitive. So yeah. And let's, same question, and we'll go to Ben.
Yeah, thanks for that, Luna. I appreciated hearing about that. So from a policy perspective, we're talking often about this constellation of conditions in kind of the American cultural container that represent, we think some of the most, just has the most disruptive potential that has existed in our lifetimes in connection with kind of humanitarian drug policy, drug user health, safety, and centering. So when I think about those movements, it's I don't want to just talk about the positive movements that that I care about socially, whether that is race, gender, health equity, criminal justice reform, or police reform, which is an issue I feel really fortunate to get to work on. But the fentanyl contaminated or adulterated drug supply and overdose crisis, all taken together with COVID, I think have created this, this set of conditions that are pushing back on other movements like the drug war, And I think fundamentally, I mean, prohibition, which is drawn like on the center stage. Fentanyl contamination and other adulterations of the drug supply are the worst nightmare that prohibition could ever have imagined, because prohibition causes poison drug supplies. When drug supplies become poisoned, history shows that they are generally irreversible phenomenon, and only worsens. And the solution, or at least the solution that the rest of the developed world is implementing, involves versions of safe supply. You have an unsafe supply. We need safe supply. But all of that goes kind of at the ideological foundations of prohibition, frankly, the most extensive, expansive, and kind of expensive campaign of communication that's ever been conducted in human history is the propaganda centered on prohibition and the drug war. And so we're up against this. I mean, I'm impressed with Apple's marketing and communications. This blows that out of the water. This is hundreds of billions of dollars spent demonizing substances and the people who use them, especially people of color. And so it's this special opportunity, this special moment in my mind, and candidly, the treatment industrial complex is really a mirror of prohibition and a mirror of the drug war itself. I mean, these are people who are quick to get on the drug warrior kind of bandwagon, and it's in their interest to do that. But anyway, the disruption that I'm excited about involves care that is able to begin to incrementally value health and safety improvements in their patients, and put patients at the center, and let them choose pathways, but also destinations that they choose for themselves.
Thanks, Ben. Okay, and then let's move to Kevin.
Yeah, I just want to briefly mention the movements and initiatives that I believe intersect with the treatment industrial complex, but school to prison pipeline, like DARE type programs, like Just Say No, abstinence type programs, goes together with structural institutional racism, approaches like tough on crime, tough on drugs, incarcerating people for these type of things. I feel like this is deeply ingrained with the upcoming drug decriminalization movements. I feel like treatment has to be, or it is, an active discussion in changing these policies. Police reform is another big one, drug checking, and I feel like biopsychosocial health inequalities as well, not only due to biopsychosocial issues, but capital, different types of capital, social capital, wealth, and it also is pretty intergrained with like mental health awareness, and just trying to get that out there.
All right. Okay, and Rory.
Yeah, one of the newer, I don't know if initiatives is the right word, but by Drug Policy Alliance, that Uprooting the Drug War is a really good series that they did recently about the intersections of kind of what everyone's been talking about, like the child welfare system, the prison industrial complex, education with the school to prison pipeline. And it really, especially kind of with the pandemic and the uprising, has exposed a lot of like the racial injustice in the both the prison industrial complex and the treatment industrial complex that I feel like communities of color have been talking about for years and years. It's just kind of fallen on, I'm spacing on the phrase I'm looking for, but it basically has gone unheard by the treatment industrial complex. And part of that is kind of the defense that they use about how many people are kind of mandated to treatment for the substances that we've been trying to advocate for. I know I did an op-ed for Star Tribune for when 2 years ago, I think, when we were kind of pushing for this bill, House File 600, to legalize cannabis in Minnesota. And one of the things that somebody from Hazelden Betty Ford had said in what I was writing the counterpoint towards was what they're calling like an alarming number of people, youth, being mandated to treatment for cannabis. And the interesting thing there is like how many people are referred from the criminal justice system. So if you removed that piece of it being criminalized or criminalizing people who use drugs, they wouldn't be getting all those referrals from the criminal and justice system. And that's one of the reasons kind of what has shown me how hard that some of these people who are stakeholders in the addiction treatment industrial complex will fight against like evidence-based harm reduction policy because it's taking away part of their profit. And we're seeing things like in Minnesota, I think it's almost 90% of the counselors are white. So that's disproportionate to how many people of color are being criminalized and forced into treatment. And then if their goal is recovery, there's a big gap there in finding people who actually understand some of the issues with trauma and racial trauma and trauma healing. But that makes it really hard for not seeing yourself represented in the people who are supposed to be supporting your recovery.
Thanks, Rory. So our next question is, what have you observed with the treatment industrial complex in opposition to drug policy? Let's start with Ben.
Yeah, and so I don't feel like, this is a question I struggled with a little bit because it's difficult to have visibility really into kind of the relationship that the treatment industrial complex has, directly kind of affecting policy, having kind of been aware of the way the trade associations and member associations are structured. But I mean, suffice it to say, that the models are centered on, right? I mean, they're concentrations of residential levels of care, that people have to kind of stop what they're doing and go away to, that people can be, remanded to under really punitive justice frameworks, and maintaining this whole, drugs are bad, drug users even, are selfish and dishonest and criminal and right. But then, I got sober and now I'm great. I'm a swell guy now, right? And just this messaging, I think is part of what they help kind of continue, and then I think just some of the tropes about, prescription opioid epidemic when that's not what we're in now, and then just misrepresenting, I think that the general outcomes that they're able to accomplish. I think that there's a lot of this like, it's, you get sober and whatever the marketing is, and 7 out of 10 are returning to active drug use, in the first 90 days after treatment. And then centering everything on abstinence in the first place is, I think, disingenuous and absolutely inconsistent with the research. So I'll stop there.
Thanks, Ben. Let's move to Kevin next.
Yeah, so I just wanted to start with what drug policy is supposed to be, and it's supposed to be for public health and safety. But unfortunately, particularly in the United States, drug policies are used to profit from people through incarceration and punitive punishments, as we all know. And I think Ben alluded to this for a second, but the treatment industrial complex and the disease model of addiction is basically a tool of the war on drugs. So much of the focus is put on the drugs, and the harms associated with prohibition are put to the side and said that they're not as important. It's not as relevant. And like everything we do in life, people learn how to use drugs. Like, You see this a lot in like Southern Europe, for example, where people learn how to drink alcohol from a young age, and as these individuals get older, you know, there's not as much alcohol abuse or misuse. Whereas in the United States, it's like, oh, you know, just don't use alcohol because it's illegal. And yet we see people under 21 binge drinking, getting into a car, you know, and we see all these catastrophic events happening because people aren't taught, like, you know, this is a drug. This is how people use it. It can be used for this. It can be, you know, used for that. It could be beneficial. It could be harmful. And I feel like these type of conversations aren't being had. And drug policy, particularly in the United States, it's used to, you know, make the rich richer, essentially. And, you know, I guess put down people who use drugs.
Thanks, Kevin. And let's move to Rory next.
I'm sure, this question is about opposition, right? Or resistance from the treatment industrial complex?
Yeah, this is what have you observed with the treatment industrial complex that's in opposition to drug policy?
Yeah, so what Kevin had been saying, and Ben touched on as well, I just wanted to mention too quick with the disease model, that it kind of has a framing that since you don't really have control of your addiction, that there's only a couple ways to fix that then. And that would be going with the war on drugs, about eradicating the drug supply. And then since with the disease model, that if people can't control their addiction or their drug use, that one way to fix that in the eyes of the disease model is to mandate people to treatment, because they're not going to do it by themselves with that framing if they're not in control. And it kind of flows with some of the 12-step too, saying that just some of the step work is saying that you are powerless over your addiction, which reinforces that you need outside help instead of working with how you want to handle or address your substance use. And some of the other things that I've seen as well have been with just some of the policies that we've been working on in Minnesota. And I've observed it in other states too, and just for federal policy as well, is that there's a big concern, kind of like, well, if these people aren't having contact with law enforcement, then how are they going to get the treatment that they need? So it's been having different types of policies still incorporate like drug courts, or with Measure 110, it had, I believe if you can't pay the fine, then you still have to go to treatment. And that's putting people in a place where if they don't have that money for the fine, then they're still getting manipulated and coerced into treatment. And part of that is still based in the fact that if everything was completely decriminalized or legalized, that there would be a lot of profit lost for the treatment industrial complex. So even with trying to add opioid use disorder here to the medical program, there are still licensed alcohol and drug counselors testifying against it. And then for the sober housing policy as well, we had like the Association of Sober Homes for Minnesota coming out and saying that they didn't want sober homes to be studied because they thought their framework was good enough. But throughout kind of the testimonies, and we had conversations for I think 2 or 3 years with people who had been in sober homes in Minnesota, and just kind of like the really awful things that happened, or unfortunately friends or family who had to speak for their friends and family that are no longer here because of how the treatment industrial complex works, or that they got evicted from their sober house and ended up returning to use and passing away from overdose. And I think I'll get into it in a question we have later on, but keying into some of the harms that you can't really look away from when people open your eyes to them is one way to appeal to policymakers, and I'll get into that later as well.
Thanks, Rory. And Luna, you're the only person that hasn't answered this question, right? Yeah, okay. I'm jumping around here, so it's not like the same person speaking first and last, because that always annoys me on a panel. So yeah, go for it.
Well, thanks. So yeah, as we know, drug policy has primarily been about prohibition, and all because it's like all about like morality, like the treatment industrial complex and drug policy have been prohibition, and it's like, are you a good or a bad person? And we see like how different drug policy is throughout like different states and at like the federal level. Like here in Colorado, which is where I'm based, the definitions of child neglect include evidence of drug use. And yet here in Colorado, like here in Denver at least, you know, they like cannabis is legal throughout the whole state. And in Denver, they're like decriminalizing mushrooms, and then there's just like broader movements. And it's interesting how like that compares to like other states where if you test positive, because like drug testing for pregnant people, even without their consent, is unfortunately legal throughout the country. So if you test positive for like any substance, in like somewhere like Alabama, like if you they'll like charge you, right, as if you were like a meth house, like if you produced meth. So it's like not only are you being charged for child neglect, but you're also being charged for producing things, even if like all you did was just consume. So it's it just makes it really difficult for people to like, if they do want help, right, to change their relationship with a substance, that's not possible, because each state and sometimes even like the cops have their own jurisdiction where like there is laws where you're not going to go to jail for paraphernalia, but even if you get caught with paraphernalia, you're going to go to court, and then your option is like, oh, you could go to drug court as an alternative, as an option. But I think another thing that's like also important is like with like syringe exchanges, for example. Like there's it's been going on for a little bit that like states like North Carolina and West Virginia are like trying to impose ridiculous restrictions and sanctions on syringe exchanges, where they're like mandating participants to be in treatment. And like even the folks who work in syringe exchanges can't have any type of experience with the criminal justice system or be like in recovery or anything like that. And that takes away a lot from like a syringe service program is supposed to be based in harm reduction, and that includes people who use drugs, and just taking that away from it. And I think laws like this, when it comes to like treatment and syringe service programs, it like creates like a syringe service program to prison pipeline, and like that's not what that should be. That should be like it's like, you know, and syringe service programs are not like considered treatment. Like, why does treatment have to be just me stopping my use? Why can't treatment just be me learning how to use the drug that maybe I'm having a tough relationship with better?Maybe I've just like have lack of knowledge to like make the decisions that work for me. So I see that a lot, like how that like kind of goes together. It's like, why are we mandating in syringe service programs for them to be run out of a treatment center, or require participants to be in substance use disorder treatment, which they haven't even been diagnosed? And this just makes it really difficult for people to actually get the help that they need in that moment. And I think it's like, it just like continues on into like just something as simple like someone going to the hospital. If like I'm going to the hospital because I inject and I got an abscess, mandatory reporting. It's like one of the things. It's like child neglect, like report if you can see child neglect or elder abuse. And given that like child neglect involves substance use, if you disclose like, yes, I have an abscess because I inject drugs, and yes, I have a child, it's like, who's to say that that nurse or that doctor is not going to call the cops on you while you're trying to get care there? And again, it goes back to like that whole cycle where it's like, not only are you being involved in the child welfare system or the child protective services, but you could get charged depending on where you are. And you're not really getting the care that you need. And it's just like making it worse when you're like trying to be a good parent, trying to take care of yourself, and being taken away from your children.
Yeah, thank you for that, Luna. So I have a bit of experience like working, advocating for parents and pregnant people who use drugs. And I said this in the chat, the Crowdcast chat here, but you know, like I'll say it again, like, you know, we all know, like, as young people, SSDPers, like, we came into this work because like we know that the war on drugs has been waged often in the name of protecting youth and like protecting us from our own drug use, but it also weaponizes children against their parents, right? And so like CPS is state violence, not much on like law enforcement is state violence against people who use drugs. So yeah, thanks for that. I find this like very interesting, and I'm passionate about it. I could talk about it forever, but yeah, it's all right. So we'll move on to
this later.
Yeah, we can talk about it later. Yeah. So we'll move on to the next question here. So in combination with policy, what do you see as a path forward in advocating for change? And let's start with Rory.
So that's a little bit of what I touched on before too, about being able to tell your story or stories for people who are no longer here as well. And I feel like that could be a whole nother session, is like storytelling for advocating for change. But there's also something that I've been noticing for this cannabis legalization bill in Minnesota, is that because of how prohibition and the war on drugs functions, that people are really hesitant and fearful of self-disclosing their cannabis use. And it goes kind of with a lot of the intersections we've been talking about. If somebody has a child, they're maybe not necessarily going to want to talk in front of legislators about their cannabis use, just because of some of the potential consequences of that, or for employment or housing. There's a fear there that if you disclose your drug use, that you could lose housing, employment, rights to having children. So I do still think that there's a way to tell those stories. We've been trying to work a little bit more like doing it anonymously and having somebody tell it for you in front of legislature, just to protect that individual from the consequences of prohibition and still use their stories to create change. And I feel like, I don't know, it's just, there's a lot of push to come out of the closet about your drug use. And I think this kind of goes with a panel that we had earlier about self-disclosure, that is super important for people who have that privilege, but there's still a lot of those barriers where people can't discuss their drug use. And it's been hard to get those stories told because a lot of those people who might have those barriers are also have intersectional identities, like they are a person of color or a parent. And queer folks and trans folks too get targeted more for self-disclosure. So one of the paths forward though is to, I think, continue to advocate for like sensible harm reduction policies, despite some of these treatment industrial complex stakeholders coming out against it, and to not really bend some of their requests, because then some of their requests have been muddying like human rights-based policies. And because of that connection between being profit over people, some things they want are to secure some of their profits, and that's how you get policies that originally were like harm reduction and evidence-based, but then start incorporating like drug courts, or don't remove some of the other barriers. And then one last thing for that too is, I think it's heavily tied with defunding the police as well, because there's always going to be targets. Still, after you decriminalize or legalize something, they'll find something else to criminalize. A lot of the times that looks like sex work or homelessness, or different people who are vulnerable to law enforcement.
Thanks, Rory. All right, let's move to Luna.
Thanks for mentioning, Rory, defunding the police, because there's so much funding that goes into those things that it takes away from like the actual resources and funding that other programs might need. So to answer this question, I think it's very clear, like centering the lived and shared experiences of people who use drugs when you're advocating. You know, we all have our place in ending the war on drugs, and we all have our own skills that we want to bring to the table to try to make that difference. But the important part is that we keep centering the experiences and the voices of like those who like have undergone treatment or been in part of the treatment industrial complex and want to make changes. Like, you don't have to be the leader, they can be the leader. Like, they can be the ones who like go and make those choices and make those decisions. And like, as someone who hasn't experienced problematic substance use or gone through treatment myself, it's like my role is to like support and listen to what you're saying, and then go and educate other people and support your actions. And I think too, like back to like that, we all have our own place. In for some folks, it's like doing direct service, doing policy. And there are many levels that you can be at to advocate for change. Like, if you want to be the one who goes work in the state health department or your local health department and have those conversations, like, do it. You're still advocating. There's people who like are into research, and they're like, oh, I don't want to combine politics with my research, but no, that goes hand in hand. So you want to be a researcher or have interest, like, go and have those conversations. It's like, we don't live in like a silo. It's not just one thing, it's everything's kind of connected. And if we have data that keeps coming out that says like, oh, substance use disorder, these are the symptoms and this is how it has to be treated, without like considering other things, then or having conversations outside of prohibition and abstinence, then and it's like, you won't really be advocating, you won't really be making that change. And we all kind of have a role. And my last thing would be to like support other movements who align with drug policy. So Movement for Family Power is someone that they run out of New York City, and they've been doing a lot of work in New York. And they've done work with Drug Policy Alliance for like changing the child welfare system so we're not ripping families away from each other. So I really recommend looking into them, and that's a way that you could keep advocating for change.
Okay, thank you, Luna. Okay, let's move to Ben. Same question. In combination with policy, what do you see as a path forward for advocating for change?
Yeah, this is a great question. And I appreciate what's been said. I think they're great suggestions. You know, I'm going to talk about some of the phenomenon that or just like areas that we can advocate in. And then I'm also going to mention a couple of organizations that I choose to do some advocacy along with. But I mean, fundamentally, you know, the root, one of the main roots of discrimination. I don't really use the word stigma very often anymore. Is it's rooted in criminalization. Anything we want to stigmatize, we criminalize. And so ultimately, I think it's important for people who are, self-disclosing that they're in recovery, whatever that looks like for them, to recognize that most of the anti-stigma conversations are exclusively focused on people who are in recovery. And those people will never be free of stigma until people who actively use drugs are also free of stigma. And so that's an area I think that's important. Decriminalization, will come before legalization, but what can come before that is a good surrogate? Diversion that's already justice-based. I mean, we all recognize that once arrest happens, particularly people of color experience this cascade of consequences that are often inescapable. Their conditions are based on, either unachievable frameworks and goals or goals that they just don't have for themselves. And so deflection is a movement that there are a couple of areas, a couple of organizations that are working on it. PTAC is the one that I work with, but that are focused on funding for and support of pre-arrest deflection, which still has problems, but fundamentally is about moving people away from draconian punitive-based frameworks or the threat or coercion that they come with, and instead into clinical containers that are highly harm reduction informed, very person-centered. You can choose your own adventure. There you don't have to do anything, no requirements whatsoever. But that's a good surrogate in the meantime, I think, for decrim. I think it's important we are able to support anybody who says they're in recovery, validate that. There was a big thing about California Sober recently, and I think that's fantastic. I'm all for, if somebody says they're in recovery, they're in recovery. And then the last piece I think I want to mention is, look, many decades ago, the movement of recovery became inextricably intertwined with what we call addiction treatment or treatment. And the truth is that it is an extremely ideologically based, group that often masquerades as providers of healthcare. And one of the big opportunities is, for people who are committed to ideology, often the only thing that they value more than that is their money. And when we're talking about advocating for change, I think that it's time, that addiction treatment, stands up and kind of puts its practice where its money is. Meaning, I think that we need to support risk sharing and value-based purchasing for treatment that forces providers to align their profit margins with the actual health outcomes of their patients. And it's one way that we can foster an ideological divorce overnight, is to force them to wake up and say, instead of forcing people down maybe certain pathways that are, that are meaningful to them, instead being forced to ask the question, to their clinical folks or whatever, what is it that we need to do today with this patient to decrease the likelihood that she's in the emergency department in 7 months, right? And when you go and look at the research, say that patient had opioid use disorder, obviously that means, writing the standard of care for buprenorphine 6 months or longer. And so it just forces them to be accountable in ways that I have a hard time believing anything else will. And so, and then just, there is a pivot that I think is important we recognize in federal drug policy, and that is, Congress used the words harm reduction for the first time a few weeks ago. ONDCP used the words harm reduction for the first time in their history a few months ago or weeks ago, and there's been an allocation of $30 million, which is nothing, but it is the first allocation that Congress made. And so there are groups advocating to center harm reduction based science and practice, in policy and in practice. And I think supporting that ultimately is critical to bending the death curve, but it's more important to global drug user health across all 50 states.
Thank you, Ben. Okay, Kevin, same question. What do you see as a path forward for advocating for change?
So I want to talk about this in a bit of a, I guess, a higher level in a perfect world. And I wanted to piggyback a little bit about what Luna was talking about research, but I feel like research funding is really important, and research oftentimes dictates what type of information is provided and what type of information is considered to be evidence-based. And that also influences policy. This also influences the type of information providers are providing people diagnosed with substance use disorder. And for an example, I volunteered in a NIDA-funded cognitive neuroscience lab for like 3 years. NIDA stands for the National Institute of Drug Abuse. And the research focused solely on the harms of drug use. And they would blatantly omit anything that can be considered good or beneficial. And that would essentially take away funding. And because these are the type of labs that are getting all the funding, this is all the type of the research that is coming out. And the research is supporting, drugs are bad, don't use drugs, just say no. And, this type of research is what gets all the money. In contrast, I worked with another research lab that focused on harm reduction, highlighting the lived experiences of people who use drugs. And like Rory and Luna mentioned, storytelling is essential when creating change, particularly the stories of people who were using drugs. And, this team pretty much went out to the Dominican Republic, established a relationship with people who self-identified as people who were addicted to heroin. They were living on the street, and their stories were highlighted through this type of research. But unfortunately, that the program was great, the research was completed, but that type of funding is a lot harder to obtain. And this lab had a lot of issues with funding versus that lab that focused on the drug abuse, pretty much had millions upon millions of dollars of funding. And so I guess to go from there, I feel like abolishing the disease model is one of the first things that we need to do to go towards that change. Like, people who have a problematic substance use issue are not powerless. And the disease approach, which also underlies like the 12 steps program, it's a source of a lot of the difficulties we see in how our society treats drugs and people who use drugs. In my opinion, as a person who, has been in the research labs, is a fan of research, I'm gonna go study things that are similar. Substance misuse isn't a disease, and it shouldn't look any different from people who might have issues with sex or with gambling or with video games. And since we can't eliminate drug use, then the elimination of drugs shouldn't be our goal. Like, in my opinion, I think initiatives like California Sober are harmful, and they could be problematic and oftentimes do more harm than good, because these type of initiatives focus on the drugs, and they congratulate people who don't use drugs instead of congratulating people who are able to remedy their problematic relationship with drugs and have a meaningful life and have a productive life. And another thing we could do is abolish the use of 12-step programs, particularly in the use in our legal system. It's a program it's basically a Christian organization. A significant amount of their methods are rooted in prayer, and it's ingrained in Puritanism. It's ingrained in morality. It's ingrained in colonialism, like how Catholicism will be like, we don't use drugs. We're more moral than that. Where there's other cultures that acknowledge drug use, and it's deeply ingrained in their religion. It's deeply ingrained in spirituality and healing. And another thing we could do is abolish forced treatment. I think we all spoke about this a little bit. And forced treatment is often touted as like an option. We're doing you a favor. We're giving you an option to incarceration. And those who are able to adhere to these goals are often the ones with the most support, with the more favorable socioeconomic factors. And the ones who aren't able to adhere to these type of forced treatments are the ones who need the most help. But the reality is that these are the ones that are harmed the most. They're the ones put in jail for like 20 years for crimes that aren't actually harming anyone. And basically we need real alternatives to these treatments and real alternatives to incarceration, not just going to drug court or going to some 12-step program. I feel like highlighting harm reduction is important. Harm reduction encompasses abstinence, and it also talks about things like moderation. And most importantly, instead of making people feel powerless, it empowers people with substance use issues to improve their lives and focus on like reducing the consequences associated with their use, not just focusing on not using. You talk about safer use practices and the adulteration of drugs on the street. A lot of people, sometimes somebody will go to rehab, they'll have their tolerance go down, they'll go to the street, they'll use a super potent drug like fentanyl, they didn't expect to get it, and what happens? They overdose, and that's unfortunate. But I feel like just like talking about harm reduction practices more, like drug checking, fentanyl test strips, these aren't talked about in a lot of like abstinence only recovery circles, because the idea is that you're never going to use drugs again. And if you're never going to use drugs again, like who needs naloxone? Like you're supposed to avoid people, places, and things. You shouldn't be next to someone who's using opioids, so you shouldn't need naloxone. And I feel like this issue is just so complex and multifaceted, and we just need to keep on moving forward. And yeah, thanks for that rant.
Thanks, Evan. Okay, so we have one more question here. It's really important, so I do want to get to it. So, but then I also want to move to audience Q&A because we are at time. So please, really brief, what changes could be made to center people who use drugs in their own treatment? We'll start with Ben.
Thanks, Rachel, for all the questions and for running the panel so well. I appreciate that a lot, and appreciate what my friends here have shared. So I think that the opportunity to center drug users, again, arises out of the conditions that we see today. And, fundamentally, good data suggests 75 to 90 million Americans will use an illicit substance one or more times in 2021. SAMHSA's data shows that only about 24 million have substance use disorder. So 66 million, if it's at 90, they don't have substance use disorder. They don't need to abstain. They don't need to go to anybody's meetings. They don't need treatment. They never did need treatment. But everybody is using from the same poisoned trough. And so because of that, the entire cohort does need support in de-risking their drug use, whether you have substance use disorder or not. And the very practices that we have rejected in the United States are harm reduction for drug users is exactly what we need to help people mitigate consequences, avoid overdose, and if overdose does occur, to not die of it. I mean, so harm reduction is critical right now, and more importantly, I think in terms of impacting treatment, and then I'll shut it down, is continuing to break the fantasies about drugs, drug users, and drug use in the United States. The idea that anybody who uses drugs is pathological. What do you mean you're using drugs, right? And if you use drugs, there's only two states you can exist in. Either you're spiritually fit and everything is grand, or you're in chaotic use and it's jails, institutions, and death. And that's just totally not true. The research says very few people live on either of those poles. And so, the real gains are not based in abstinence. I mean, even if 1 million people out of the 3 that get cared for sustain abstinence, the kind of the cost containment and the health benefits are nothing compared to 10 or 15% improvements to health and safety across 90 million Americans. Everybody deserves autonomy, self-determination, rights of agency, and informed consent, including to live the safest, healthiest version that science can help them live of the life that they choose for themselves today. Having substance use disorder does not diminish a person's agency, not 1%, not legally. And so I think we need to support drug users asserting rights to agency, and support normalizing incremental valuing and celebrating incremental improvements to drug user health and drug user safety.
Thanks. Okay, let's go to Rory.
One thing within the treatment, I suppose, is to, well, let me go back a little bit. One major approach for addiction treatment has been that they're only focused on one stage of change, and that's the stage where people are like ready to stop using, ready to make change. And in reality, stopping drug use might not be a priority to that person. Somebody might have like the main goal of getting their kids back, finding housing, employment, dealing with trauma, dealing with other mental health. And that really needs to be implemented into like the treatment planning structure of people. And even an approach I personally took was just to let people set their own goals. Like there doesn't have to be like a cookie cutter treatment plan for every single person. And for like something that could support somebody's recovery, it could be something like incorporating different cultural pieces too. Like I had clients, Indigenous clients who benefited from going to sweats or drumming. And that's part of a way that treatment professionals can support somebody's recovery is what they want, what makes their life meaningful to them, instead of focusing on just like complete abstinence. There's different ways where you can support somebody's autonomy and what they want to do with their life.
Thanks. Okay, so then let's go to Luna and then Kevin, and then we're going to move to Q&A because we are 7 minutes over time, but I really wanted to ask this last question because it was important.
Yeah, thanks. So just briefly, I think something that's like really important for treatment professionals to be able to like center the experiences of people who use drugs in their own treatment is like recognizing power dynamics. Like we live in a country where it's super fucking illegal to do drugs, and I'm going to saying like, hey, I have a problem. And you know, there's like that power dynamic that as if you're a mandated reporter, you can call the cops or call someone's probation officer or something like that. So just like recognizing and like having those conversations that like you might not be necessarily the person that someone who is in treatment for their substance use is going to trust, and that they're being vulnerable with you, like coming to you, whether it's like forced or not, like, hey, you have to work together. So realizing that power dynamics are very, very real. And treatment that isn't just medicalized. It's like for someone, it might be, hey, I do need to go to the detox and just, I can work it out, but someone else might need something different. And it doesn't always have to be like with a diagnosis, like it doesn't have to have a diagnosis at all. Like they're just coming to with you for help. So I think those are just some two things really briefly that I think could be helpful to centering people who use drugs in their own treatment.
I'll make this brief and just focused on three things. So stop making abstinence the goal and start making the goal life full of purpose, a meaningful and productive life. Second, encourage honest and open conversation about drug use that acknowledges the harms alongside the benefits. And three, stop acting like 12-step programs work and are effective and acknowledge the harms that come from it. You know, if those programs don't work for somebody, it's always your fault because you weren't working the steps. And the only alternative, as Ben mentioned, is jails, institutions, death. And in reality, research suggests that people are just as likely to quit using drugs without intervention and compared to the 12-step programs.
Great. Okay, so we have like literally 7 minutes, and then this like the broadcast will end because that's like how Crowdcast works. So first questions from Luis. Where can young drug policy reformers start to learn more if they aren't familiar with the treatment industrial complex and want to engage in the work of changing it?
I'll be quick, but I went from the drug court to SSDP pipeline, so join SSDP.
I was just going to say quick to talk to people who have been through the treatment industrial complex too. People who have had both positive and negative experiences, especially folks of color and those with other historically oppressed identities.
Yeah, and I wanted to add, there's also the Just Say No, like KNOW program from SSDP, and for me that was very educational and like just kind of being able to like learn how to make connections within like substance use and the war on drugs. So I think that would also be a good place to start to just get some general knowledge, and it helps you how to make connections.
Yeah, I think SSDP is the place to go. I think you guys have those resources, and that's what I would encourage. I'll include my email. I think it's already in the data, so anybody who wants to reach out, I'm happy to dig deeper on that. But I think you have a lot of resources at your fingertips.
All right, and then I'll do one more question really quick from Ville Marie. Many SSD peers, myself included, have worked or aim to work in the substance use disorder treatment field. How have your experiences working within this treatment industrial complex contributed to your advocacy and SSDP related work?
Yeah, it was working in a rehab that made me really want to work somewhere that was centered in harm reduction practices. You know, when I was working in the rehab, I felt like a lot of folks were just getting mistreated. I felt like their opinions didn't matter because they had this disease of addiction, and anything that came out of their mouth was garbage. And so just encouraging different types of treatment, and yeah, sorry, I just lost my train of thought, but yeah, that. Yeah, that encouraged me to that working in the rehab space is what encouraged me to get into SSDP and harm reduction and abolishing the war on drugs. You know, like seeing those harms and like seeing the harms I experienced during like street outreach with people using drugs in the street. You know, those are things that have motivated me to do the things I want to do.
Yeah, so I could have a whole session about this too. My experience working and going to school for it, like I said before, it's mostly white providers, which was represented in my schooling as well with other white students, and there's a lot of racism that I faced going through school in my program, and also resistance to harm reduction, and really no movement from that forced abstinence kind of 12-step model. I feel like one tip for me is from me, I suppose, is working at a program that reflects your values instead of trying to find someplace that you have to fit into their mold, because you'll burn out really quick. And for me, it was really hard to support clients when they're subjected to all those rules. And there's really nothing I felt like I could do sometimes to prevent somebody from being kicked out for no reason. And then just creating difference, or that there's different sectors, I think, of how you can support people who use drugs and people in recovery. And another quick thing too is there's been more of like a movement to decolonize too. And some of those things that are rooted in psychology and other facets that are colonial aspects of treatment.
Yeah, so I've worked as a case manager in a syringe service program. Not necessarily treatment as it's seen, but I feel like for some folks it is. And I think my experience with supporting folks has been like how over and over again, they're just kind of like saying that they're not worthy until they actually complete like an inpatient program. It's like that everybody wants an inpatient program, but they can't get in because Medicaid won't pay for it. So I think that has influenced a lot of my work, just seeing like how hard it's been for folks and how that it causes a lot of internalized stigma.
All right, so that's time. Like the stream is gonna end in like a minute. So thank you everybody for being here. This has been a really great, fascinating and like definitely very thorough conversation about the intersection of U.S. drug policy and the treatment industrial complex. If anybody wants, like, feel free to drop your contact info in the Crowdcast chat. But it's been really nice chatting with all of you. And come to our dance party. That's tonight at 7 Eastern, 11 p.m. GMT. So it'll be really fun. Thanks, y'all.